such that it felt local here, severe pain in gait.
So have you had pelvic girdle pain or SI joint pain prior to 3 weeks ago? Or this onset was 3 weeks
It's
ago?
off and on, but I'm a walk it off kind of guy.
Okay.
Ignore it.
So long sort of history of left-sided pelvic girdle pain that you could usually manage, and then 3 weeks ago it escalated, it sort of increased?
It's been on the increase over the last, I think, year.
Increasing
With
over the past
episodes.
year?
It would come and go. Intermittent episodes.
Okay. All right, intermittent episodes.
Unrelated to actually seeing.
So there's no activity that you, or event that you can think of 3 weeks ago or at any time that has caused this to get worse? Have you just been noticing it's progressively just increasing?
Well, fortunately, I have a consistent exercise routine.
Yeah.
And so I'll do a combination of high incline outdoor hiking and really vigorous.
Yeah.
And I feel left-sided weakness in my glute, in my extensors. It's very evident.
Typical patient, right? Typical patient. What was the question? Have you had an event?
Well, the original event, I'll tell you.
No. So have you had any trauma to that side of your pelvis?
Yes.
What happened?
Did you say that and I totally didn't listen?
Because it's so true, because his head is so full of all the things he wants me to know that's going on, and we're going to get to all of them, right? And I just love the fact that Chris is taking the seat of the patient in doing this.
That's
Thank
the only
you
reason I'm doing that.
Yeah, no, you are, and it's perfect because it just highlights and showcases how easy it is for patients to go off track and off the question, and then how we go, that's cool information, I need that for the future, but I'm not gonna stop him from telling me that. I need that information, but I'm still gonna get the answer to the question that I want, right? Has there been trauma to this pelvis?
So, when I was 10 years old, there was a car coming, we were playing in the street with friends, I'm 10 years old. We knew we were gonna get killed because the car was coming towards us fast. So they ran across the street and I ran in between two parked cars, and unfortunately he crashed into this parked car. So I got pinned in between, and I just immediately took my hand, I took my hands and put it on each car, and some people pushed the car apart because it broke the brake, and then they said, "Can you walk?" And I said, "I'll try." And I felt inside my leg a separation. My foot was still on the ground, and I felt like I wanted to walk, but I felt this, and I said no.
So what was
So I just waited until the ambulance came like this, until they put me on the ground.
So was something broken? What
This
was it?
big femur is fractured,
Okay, so
totally
then
fractured.
fractured femur.
And my pelvis it's bashed in, the bone is changed, it's 10 years old, so
Was
it's all.
was the innominate fractured on that side as well?
Yeah.
Fractured left femur and a fractured left innominate.
And I had 2 wounds, about an inch on each where I was bleeding.
Okay, and this is the event you're telling me about that you were put in long traction for 4 months or something, right?
So long traction for 30 days in the hospital, and then they put me in a body cast called a spica, and this is the old-fashioned
Yep.
plaster.
Yeah.
Really heavy, with my legs spread apart with a bar,
Okay.
and for 3 months.
3 months,
Okay.
at the age of 10.
Yeah.
What's gonna happen to the form closure mechanism of that SI joint, right?
I think Chris said right femur, right?
My right femur was fractured.
Not
Oh, sorry,
left.
yeah, right
And
femur,
left
thanks.
innominate.
Yeah, the right femur, left innominate. Yeah, so that's why you always wanna know, what's the first trauma? What's the first thing that had happened? Because Chris has a story now that could suggest that he may not have developed, awesome form closure for that left eye joint, because he's also told us that he's a dancer, that he was a dancer, right? So, were you dancing in your teenage years?
No, I was
No?
very active on the street, climbing fences.
So when did you get into the movement world of that would have, and I'm talking to you as a physio now, correct? That would have the potential to maintain mobility of the SI joint. Things like doing the splits and opening up your hips and
I was working out with a gymnastic team in high school.
in high school.
Yeah.
Okay.
I didn't want to be on the team, I was too busy.
So when you were working with him,
Working out, I was training. with
training out with
Yeah.
him.
So I was working on my
were
splits.
you were working on your splits
yeah.
as a teenager.
Yeah.
Okay, all right. Working on splits in gymnastics. Okay.
From
So
14
my
to 18.
questioning, my questioning now is really all the line of what did he do in the formative years that could also prevent form closure development? We know for sure we're going to be doing a passive control test on this joint. It may even be the first thing that I do before even finding drivers, sort of giving the story. Because now he's got this chronic left SI joint pain. Can he really stabilize it? My brain initially was going with intermittent episodes, looking at, I gotta look at sacral multifidus, I gotta look at what's happening to the core, that sort of thing on it. But then other events have happened in your life, Chris. So what's next? What was the next trauma that you
Oh, I was teaching in Toronto in 2014, and all of a sudden I got sick while I was teaching. So I told my teacher, he's a partner in our company, Canada. We have a Canadian company, and I came up to him and said, he's looking at me like something's wrong. I could see in his eyes. I said, I don't know what's going on, and then I collapsed. And, I went out, and I basically had a near-death experience.
What?
Heart attack.
Is that when you ended up with your bypass?
Well, I basically went inside a cocoon, and I just had to shut out everybody because they were telling me don't close your eyes, but I knew I couldn't. I had to close my eyes.
Sorry.
Oh, keep it rolling.
Yeah.
Keep it rolling.
Sorry.
It's okay. So when I woke up, the paramedics were there. Luckily, it was St. Michael's in Toronto, one of the best hospitals. So they said, sir, we have to cut your shirt. This is after I went into a deep, almost felt like a coma, and I couldn't hear anything anymore. I don't want to get into, I couldn't tell you that
that's
story,
okay.
that's another time.
That's
There's a
okay,
whole
but-
near-death experience,
Wow.
but I'll tell you that's another
Sometime
time.
over a glass of wine, but yeah, let's keep.
And so when I came out of it, I was in the tunnel, and then I came out of it when I decided to stay. I was given a choice to go or to stay.
We're happy you joined us.
And then I came, I woke in, and then paramedics were there, and they said, we have to cut your shirt to put the leads on to do the EKG. I said, really? It's a Lululemon, it's expensive. So luckily my humor came back. And so they cut my shirt. I said, I'm just joking. And they said, yeah, you're having a heart attack. We're going to give you 2 baby aspirin. And I said, but I'm an adult. Why you give me a baby aspirin? I'm just kidding. I'm sorry. And they're like, Chris is back.
Yeah.
And then I went to the ER, and I had a stent put in 15 years before that, 12 years before.
All right, so you knew you had a bit
At
of
a
heart
very young,
issue.
at a young age.
At a young age, yeah, okay.
I was never overweight, never smoked. And then they said the only treatment we have is a triple bypass. I'm like, are you kidding me? They said you can go home now, but you have to wait 2 weeks in Toronto, and then you may have a heart attack while you're waiting to go back to USA, and then you may have a heart attack on the plane. Do you really want to risk that? They didn't give me much choice, so I said, okay. I mean, they talked to my wife, and okay.
It's a good hospital.
So they cut through the sternum and took my veins. Some veins.
Yep. And triple
But
bypass.
honestly, I feel like nothing's happened. There was no heart damage. I actually had no heart damage, so I'm really fortunate. They said, you just have new pipes. Great. So I can do anything that I want to. No restrictions, strength,
Nice.
running,
Nice.
sprinting.
Did you notice any difference in the mobility of your thorax with rotation after?
So, yeah, I'm hypermobile, I believe, I've been told, and I believe. So that was the hardest thing, was, I feel like I've restored, there's still some internal things going on. I know there's some things pulling, I can feel it. When I go in certain directions, there's something.
Something inside, could be an osseous lesion or something in the bone or something like that.
I
Okay.
did have pericarditis for a short time. So,
All right. So with all this experience in and around your heart,
oh, 1 second, sorry. I was supposed to sleep on my back after surgeries to not disrupt the healing for 8 weeks. It's hard to, I'm not a pure back sleeper. Most people move, so
Yeah.
I think I may have shifted things in the sternum during the healing process.
okay?
I don't know if it healed perfectly.
All right,
think
well, it's
it'll-
definitely something we'll look at. And do you feel that this operation on your chest had made any difference to your SI joint pain? Were you having,
Can't say.
can't say, okay, no idea if those are related. So let's go back to your primary complaint right now, which is chronic increasing pelvic girdle pain. And it was aggravated three weeks ago. What activities will provoke your pain, your pelvic girdle pain now?
I don't think there's anything that it doesn't hurt to do something. I notice an asymmetry and I ignore it. There's asymmetries in my pelvis and I can squat, they feel different, both sides.
Yep.
And I just do it, but I try not to hurt myself. I try to keep placing my feet until I have my strategies to keep finding the perfect place to feel a smooth squat and not just squat.
So this is the perfect place, a segue in the story for me to say to Chris exactly what I say to most patients who come to see me. We don't treat pain in this clinic, we treat function. What can I help you with that you're struggling with functionally? Because I'm not going to be able to find a task that provokes his pain and then do corrections that change his pain. So I'm not going to use the symptom part of his experience for finding a driver. I've got to look for something that's related to performance, right?
I know my left side is just very different than my right. It feels like two different hips.
In what task? In
Climbing a mountain,
climbing
going
a
up a
mountain.
mountain.
Okay, so how am I gonna simulate climbing a mountain? Would that be more like going uphill or downhill,
Uphill,
like a
always
step
uphill,
up?
never downhill, always
So
uphill.
do you feel the difference when you're climbing
Yes.
stairs?
Not so much stairs. I
So-
don't climb stairs that much.
If you were to take a step up on something, would you notice a difference
It have
one
to be
side?
high.
Kathy, can you bring me the Pilates box, the box please?
It would have to be a high step.
Have to
or-
be a really high step, okay. So what I'm trying to do now from this story is find a meaningful task. And find a task that Chris is going to do frequently enough that when he comes back, and I ask him, so how are you feeling? I know exactly what symptom, and by that I mean an experience of this doesn't feel right. Remember, in choosing a meaningful task, it could be, yes, something that provokes pain, but it can also feel something that feels different or doesn't feel right. And that's what we're going with Chris, to find his meaningful task. I have to be able to duplicate something or produce something in the clinic where he goes, yeah, this feels different, and it is kind of like my hiking, which is the first thing that came out of his mouth, okay? So just take a step up onto the box.
Just
for me.
one real quick thing, when I was a dancer, professional dancer, we all have a dominant leg.
Yep.
In a dance, you always lift your favorite leg, because it looks better. Mine felt even worse on that left side.
So standing on the left side or
No,
lifting?
lifting,
And so,
and weaker. It was always weaker
okay,
and less mobile.
okay. So come on up to standing for me now. Let's just see if this is the task we're gonna do. Just take a step up with, we're gonna do it both ways, so one side and then the other, yep, and then step up,
Oops, sorry.
Yep.
There you go.
and then the other one. Any difference from side to side?
Minimal.
Minimal difference, okay. So that's not gonna do it for us, all right? Okay, so now just stand on your right leg for me. And then stand on the left. Okay, I can see a difference. Can you feel a difference? Yeah, there's a bunch of things going on when you stand on that left leg, right? Stand on the right leg. He finds his center really fast, really easy. Looks easy to do that. When he goes to stand onto the left leg, yeah, it's a little bit more hard. So single leg standing is going to be a prerequisite, something that you have to do, to hike, to walk, to stand, and it's something that you do every day. My suggestion is we look and see what's going on with single leg standing, and then you're gonna be able to take that forward to see if we find a driver for that is yes or no in relationship to hiking. I wanna try one more thing. Stand on your right leg and lift your left knee as like you're climbing a mountain. It's really high. And back down. And now stand on the left leg, do the same thing. Yeah, and really, that's gonna be our task, Chris. Would you agree?
Sure.
Good one to start with?
Sure.
Okay, all right. What do you think is going on? What do you think is going on with your pelvis?
I
Let's
think
see.
from my accident, and I've gotten away with it for many years and ignored it. It really didn't give me problems. I always knew it was a little weaker, a little less mobile, but I lived with it, and now it's catching up.
All right. I think that's a really very realistic cognitive belief, and I think even if we find a driver for his pelvic control that isn't in his pelvis, it's something that I'm going to include in this assessment, because this will be assessing his cognitive belief and mine. Does he have good form closure of that left sagittal, right? And I don't ask people, and how are you feeling about this, right? When he talks about his accident and he talks about his experience with it, he has what Dan Siegel would say, fantastic integration of his hippocampus and amygdala. So he can tell the story with no emotion. He can tell the story and the autobiographical details of that story, and it doesn't wake up the emotions that he must have had when he was 10 years old, when the whole thing had happened. He can't talk about his heart surgery in that way, right? So you can see that there is still some trauma resolution to be done, but it's not around this trauma, it's around another trauma, okay? And that story is not fully integrated yet. There still will be triggers for Chris with the trauma around his heart, okay? But it's in the telling of the story that you get that information, rather than asking the question, all right? Make sense? Okay, so I have enough information to start. There's obviously way more questions we could ask, but I always try to limit, and that's a little bit longer than I do, because we've now got half an hour to finish up what I would do. I am not going to talk to you anymore. I'm just going to fly, all right? So you can see what it's like. So get out your pens and papers, write your notes. We've got it on video. Kathy, if you can chart for me, or Brittany, if you can chart for me, that would be.
Should we do it up there?
Yeah, sure. Let's do it up here. Okay, yeah, sure. Yeah.
I'm assuming she's gonna see questions.
Okay, and I'm going to
He's like, Kathy's going to fuck. Your mom is there. Your mom is there. Oh, I think I need to. Move this one back then.
Hey, Lou, obviously I'm tall, so I'm supposed to go out of frame, so.
No, you're in frame. I'm trying to my best to get you in frame, but I might have to change this.
Can you pop your slacks on for me?
Yeah, I figured.
Because I think she's gonna do it in standing and then in laying down. So when it's laying down, I probably have to move it up to the bed. But then the thing like it's a lower angle, right? Yeah. I'm a good cameraman, so we're good.
Yeah, all the way around. Yeah. Okay, so our standing screen is or our start screen is going to be in standing, and our meaningful task is going to be standing on the left leg with lifting the right knee up quite high, as in for hiking. Okay, so with his pelvis, he is standing in a left transverse plane rotation, a left lateral sway. Shift your weight to the left body, your whole body, like you're going to stand on that leg. Good, and then just come back to standing. Take your weight to the right, and then come back to standing. And that left lateral sway is associated with the left lateral tilt. Left iliac crest is up high. So left lateral sway, left lateral tilt, and a left TPR. And a left IPT. And down into a small squat. Coming back up to standing. And go down again. And back up. His right hip is anterior to the left, which is congruent with his pelvis. But you're staying left today. Yesterday it was variable, it was right, it was left, it changed. So now, come up to his thorax. His lower thorax is rotated to the right relative to his pelvis, so it's incongruent. There's going to be a lower thoracic ring, 10, 9, 8. 8. 8 is translated left, 7 is translated right. 6, 5, 4, 3. Actually, mid thorax is pretty stacked quite nice, actually. So the big things I'm picking up was this one. 1, 2, 3, 4, 5. So 6 is translated right. Six and 7 right, 8 left. Is that what I got? Yeah. 6 and 7 left, 8 right. Okay. All right. So stand on your left leg for me now. And back down. And go again. And back down. And go again. Back down. First time he did it, he was stable. Second and third time he did it, he gave way. So unlocking left SIJ in left one-legged stand on the left leg again. And he still stays in a left TPR and a left lateral tilt and a left lateral sway. And back down. Stand on your right leg. And back down. Stand on the right leg. Down. Yeah, and he's got good control on the right side. Okay, turn to face Kathy. Come down into a small squat. And then back up. Stand on your left leg. And back down. So his hip, it's not translated, and back down. His left hip is not translated anterior to the acetabulum, but it's right at the edge of it. He loves to shift that hip, his femoral head forward on the left side. And he's not in center. There's a real, he has difficulty finding his center of this left hip when he stands on this side, okay? Stand on your right leg for me now. Yeah, and this one stays in center, much better. Right hip stays centered, the left hip doesn't. And that's not the task. I know the task is to the left, but I just wanted to compare it from side to side. All right, these rings, 8 left, 7 and 6 right, so I'm gonna feel all 3 of them at the same time. Stand on your left leg. 8 gets worse. 8 translates to the left. 7 and 6 stay the same. Alright, so I have 3 sites of impairment. I don't like what this hip is doing. The SI joint is unlocking, and the 8th thoracic ring is translating more. So, I'm going to start in the thorax. You can start wherever you want. You can pick whatever color of paint you want to start with. So if I cannot correct the 8th thoracic ring. It is absolutely hard, solid stop. Okay? I cannot correct the 8th ring. I cannot correct 7. I cannot correct 6. These are very, very stiff rings. Soften your sternum a little bit for me, Chris. Just really let your back relax, go into flexion a little bit. Quick, and then relax, go back to center. And really relax again. Yeah, no. Those are just really, really stiff. There's no change in that thorax at all. I cannot correct them. Okay? That's it. Andrew can feel this.
I get chronic tension here.
Yeah.
Right in here.
Okay, put your hand where mine is, just so you feel this. So try to posterior rotate that rib. That's when you go articular. That's an articular system impairment. Okay? That's what you were asking me yesterday, right?
Yeah.
That's articular. Okay. Alright, so I am now going to provide some force closure. I'm going to try and correct this pelvis as best I can. Now stand on your left leg. And back down. I absolutely know that's not going to change his thorax, because if I can't change it with my hands, correcting his pelvis isn't going to change it, right? And down into a small squat. And I'm just going to place my hands just inside the ischial tuberosity, inside your inner leg. Are you okay with that?
Totally.
Okay. When you get anywhere near pelvic floor, you always get consent, right? Create a little bit of space. So I'm lifting the ischial ramus and the ischial tuberosity up towards the ceiling. I'm going to center the femoral head. Come on back up to standing for me now. So I'm going to check the task first, because I want to keep this correction. stand on your left legs. Back down. And I'm gonna try and hold this, so I'm pushing his innominate forward with my thumb, pushing his femur back with my hand, so that I can feel what happens to this left SI joint when he stands on his left leg. Stand on your left leg. And I'm gonna let his hip go. And there goes his SI joint. Okay? So correcting the hip improves the control of his pelvis. Okay. So now I throw a belt on him, but I'm not gonna do that, so Ashley can get in here. I wanna really force close this. I need to correct the pelvis. It's a difficult correction. I want you to feel the hip. So come onto his hip now. And stand on your left leg for a minute. And you can feel how he gets a divot back here, it goes soft, and the femur goes forward. I wanna see if that changes when I correct his pelvis, okay? Go back down. And how I would do this in the clinic is I'd rely on patient experience. So correcting his hip, I like what happens in his pelvis. So now I'm gonna try, take out the tilt, take out the sway, add the force closure, I'm not on his hip. Now stand on your left leg. And now I'm gonna let the pelvic correction go. I'm gonna watch what happens in his hip.
Yep. More anterior.
Yeah, so correcting the pelvis improves his hip. Correcting the hip improves his pelvis. I wouldn't say that either one of them completely corrects the other. So I asked Chris, which felt better to you?
It's kind of hard to tell.
Hard to say?
It's like going to the optometrist. Does this
I
look
is
better? Does this look
exactly-
better?
That's exactly what this is.
I'm happy to do it again, but maybe you don't want to do it again.
Not at all, not
Okay.
at all. So I'm not sure either, because I think he's probably got impairments in both, right? So how am I gonna co-correct his pelvis and his hip and see what that feels? You'd have to be an octopus, right? So he has pelvic girdle pain. I wanna know what his form closure mechanism is like. If there was clearly a difference between these two, I would run with it and then just throw in the form closure test at the end. But there isn't a clear difference between these two, right? But because his pain is in his pelvis, I'm gonna start there. I'm gonna start looking at the pelvis. And I'm gonna see if I got a little bit of time left at the end to do something with it, with his hip. That's where I'm gonna go, okay? All right, turn this way for me now. So, she's such a good printer.
Yeah.
Wow.
Gotta add something? She always does when she's quiet. Go for it.
TR678, you can't correct.
I can't correct.
So we don't really know the impact of the force.
We don't, we don't.
So you're just gonna stay in the pelvis.
I'm gonna stay in the pelvis and the hip right now, and that's what I would do clinically, because I want, if I, when I look up here, Kathy, and I see like this massive amount of erector tone he's got on this side versus this side, his scapula is down and low, but when I take his pelvis out of this tilt and bring this back,
So it doesn't.
I like what I see that
So-
happens
okay.
higher up,
So
okay?
it improves the
So
upper
that,
thorax, but no
that
change.
right erector, like he's also got hypertrophy on this side, because he's been in this position for a long time. This is up, this is down. Amy, this is a reactor,
No,
right?
look at
Because his
that.
pelvis is down on this side. Okay,
Mm.
this is under stretch. This is under stretch. And it's a really hard correction to get him onto that tilt.
And if
Okay.
you stood sideways with one hand on the ribs and you moved either like his like liver around or stomach or heart, would that change ribs?
Oh, it could, but I'm gonna stay in the hard frame until I find the driver, first of all. You okay if I take these down a
Oh,
little
yeah.
bit? All right. Okay, so here we go. Let's a further assessment of the pelvis. Active mobility. Stand on your left leg. This is a July test, Fairbooth test. Goes by ipsilateral kinetic test in Canada. Leg back down again. Either need to go up a little bit higher, my dancer friend. A little more, a little more, a little more, a little more, a little more. And then back down. Lots of hip mobility. Very small amount of SI joint mobility on this side. So again, we're talking active mobility, not passive. His SI joint does not begin to rotate until he gets his hip well above 90 degrees of hip flexion. Stand on your right leg, lift the left. This side. Okay, down again.
You heard those? Do you feel that cracking?
Yeah.
Something.
Go again. And down. And one more time. So what I feel happening on the left side though, Chris, is even a smaller amount of movement actively on the left, but now the innominate takes the sacrum with it. So it's almost as though there's a ton of compression between the innominate and the sacrum, and it moves a little bit, and then both sides are moving. I'm not getting a clear this. So the active mobility, we don't look at hypermobility now. The whole myth of young women move a lot, old men don't move much is absolutely false, okay? So it really depends on what you've done with your pelvis in your formative years in terms of how much movement you have. So we look for symmetry, just like every other joint in the body. Does it feel the same from side to side? And this is asymmetric, right? And the left side is actually actively moving less than the right. Doesn't mean it's stiff. It's just what the strategy is that he's doing, okay? The lateral tilt and the lateral sway is not about his pelvis, it's about his hip. It's the movement of the ring on the hip. So when I assess the pelvis, what I'm assessing to start is intra-pelvic function. What's happening at the pubic symphysis, what's happening at the sacroiliac joints, okay? That's your active mobility test. We already know as an active control test, he has unlocking, loss of active control on the left side in the task. So I don't have to repeat that, okay? So now I need to know what's the passive mobility like of these joints and what is the form closure mechanism like, okay? Lie on your back and there they grab me a pillow behind that. Yeah. He's cold and I'm sweating.
I'm such a wimp.
Arizona.
Is that okay?
Where do you want my head?
On your,
Down
there.
This is under me.
That, up.
What's up on my head?
Oh, yes, sorry. Did you say something else before?
I know, but he's
Oh, but if Diane's gonna be over here,
Ah,
we're not
you
gonna
don't have
see
to.
much.
I just thought you might, if you don't have the pillow, take it away.
This is not the side I ask her. I think she will probably touch the other side too. She will. Goodness, true.
Okay, so. So that's what I love. So this is where we are going after coffee break. So, well, active mobility first. Now, just let your legs rest against, left leg rest against me. This one, yeah.
Okay, I'm doing this. Is that
That's perfect, that's fine. Yeah, that's fine. Just need them, everything relaxed. Okay, so I got, this is the plane of Chris's joint on the right side. There is lovely movement top, middle, and bottom, but it's a little compressed at the top. So the neutral zone of motion is reduced at the superior pole. Top part of the joint is compressed. But that's not a stiff joint.
When you say
Left side. So I slide my fingers under the pelvis. I run my fingers around in a circle to find the PSIS. This is why we did it yesterday morning, or day before, in the morning. I then curl my fingers medial to the PSIS, and I push into multifidus. This multifidus is not at full capacity. So think about feeling a bicycle tire. You get your bike out in the spring, you're gonna go for a ride, are the tires nice and ready to go? So I feel the thoracolumbar fascia. This is what we missed on day one. We feel the thoracolumbar fascia, and as I press through that, I think of avocados. Is this an avocado I would pick for salad? Is this an avocado for guacamole? This is a guacamole multifidus on this side. It also has some stringiness in it.
I wouldn't buy it.
So when you get to the part in your support, you're going to find an article by Paul Hodges on what happens to multifidus over time with chronic back pain and pelvic girdle pain. This is late stage changes in multifidus with fibrosis. So this has been here for more than 9 months. Okay? You get fatty infiltration first of all, which makes it become that softer feel. And then you get some fiber conversion to fibrosis. But he has muscle here. This isn't a lost cause. We can do something with this multifidus. But he doesn't have enough capacity, I don't think, in his multifidus to fully tense the thoracolumbar fascia and force close that SI joint, okay? But I haven't tested that yet. That's just what my palpation of the muscle suggests, right? And this is what we're doing tomorrow morning, okay? Is multifidus. Today, we gotta find the joint glide. It's the strangest pelvis on this side. It's like a big hole here. What happened to this bone? That's that fracture thing from your 10?
Yeah.
It's like, yeah, this is exactly like Cliff's pelvis. What I was telling some people, like years and years ago, we were doing some osteopathic courses, and I had to find where the ASIS was on Cliff, and I couldn't find it, and I kept saying to him, "Where's your ASIS?" And he said, "In my nose." They had taken the bone to replace his nose. He was a boxer. This feels exactly like. Yeah, it's really hard. It's really hard, and I am getting a ton of compression. Okay, so I can find the plane of this joint, but the top, the middle, and the bottom are really bouncy and really compressed. This joint is very, very compressed. And so I don't have a clear glide. Compressed is by muscles or fascia or something compressing this together, okay? So I'm gonna let him let his leg go down really straight. Really, and probably that one too. I'm gonna let you go into an IPT, I don't care, because we really need this to relax. To really, I'm not gonna be able to check the form, there we go, there we go. So, when we really turn off everything, the amplitude of movement does not feel excessive in the sense, or hypermobile. It feels very similar to the middle and the lower poles on the other side. It feels the same. And so now the next question, his SI joint was compressed when his legs were up because he was firing his muscles. But when I really get him nice and relaxed, where I can actually really check the joint passively, he's got lovely movement, top, middle, and bottom, and it's not excessive. I'm not going, whoa, all the way through into this thing. So now your form closure test, passive stability test. It's not a stress test. This is not a pain provocation test, although it will provoke pain if the ligaments are sensitized. It will hurt. The intention of this test is stability. This is the Lockman's test of the knee. This is the Hawkins knees, the shoulder test for capsular integrity, okay? Form closure mechanism test, passive control test, all means the same thing. So what am I gonna do to this sacrum? What's the closed pack position of this joint? Nutation or counter nutation? Nutation. So my fingers are now gonna push his sacrum up towards the ceiling. And I push that a long way, because I have to get through the multifidus. I'm now simultaneously going to posteriorly rotate this innominate. And I always warn people, this may hurt a little bit. Let me know if it gets too intense, because we gotta go right to the end field. You good? Okay, there's the end field. This joint is solid as a rock. He has healthy form closure. Healthy form closure.
That end field would be similar to a Lockman's, like a solid
Yes.
bang.
Bang. Just like that.
Yeah.
Solid. Or that. Closed pack, check for shear, no movement. It's the same orthopedic test we use in every other joint. And in pelvis, nutate, and what people often do is they let the nutation go because their fingers aren't strong enough to push up. So I'm just pushing through a multifidus mush, right, on this side. I can feel, and that's what came to me in this story, right from the get-go. Intermittent increasing flares. Okay, so now where I'm going is my right hand is on his left multifidus, my right hand is on his left multifidus. This muscle is really healthy. If we put an ultrasound on this, the quality of this just feels like the best pizza dough you can imagine. It's so homogeneous, there's no strings in it. It feels like an avocado that I would pick for a salad, or for sure. And this one over here, you guys feel the difference in the sinking in, right? Okay, so now, with my left and right hands on multifidus, they have not done a study looking at whether or not the pelvic floor should cause multifidus to contract. I can't believe they haven't done this yet, right? They think it should, but neither Paul nor Julie has done it. So, I think it should. So I'm gonna ask Chris to connect to his pelvic floor with whatever that means to him, okay? So often I would say, do you know how to do a Kegel? Do you know how to contract your pelvic floor? Go for it. Yeah, And I feel the right multifidus come on a little bit, but the left not so much. Now, multifidus is more responsive. The brain map and motor map for multifidus is more related to movement. So it's a muscle that comes on in anticipation of load, okay? So I'm going to, similarly, you can do this one side at a time. I like to, when I can get my hands around a person, feel both at the same time. Use a loading task and see what happens. So I'm gonna ask Chris to just lift your right foot off the table for me. And back down, and lift the left foot.
That hurt in my SI.
Yeah.
It hurt again. Every time I think that hurt.
Fantastic. And the multifidus is not coming on, okay? Now, EO, IO, TA, pull and separate, low fibers of TA. Connect to your pelvic floor again, beautiful. Transversus comes on like that when he thinks of his pelvic floor. Now, I don't know if he's, for certain that he's contracting his pelvic floor, but whatever he thinks is a pelvic floor contraction is getting a beautiful, normal response in his TA. If he had issues of perineal pressure or hemorrhoids or testicular pain or was complaining of any pelvic floor symptoms, I would get out the ultrasound, I'd throw it on the suprapubic region, and I'd watch what happened to his pelvic floor, okay? Part two, do that part two, okay? But I'm not gonna go there with Chris, because I really think that this issue is his multifidus, okay? So, to confirm that for Chris, I'm gonna force close his pelvis at the back, and I'm gonna provide the force that multifidus should be doing, which is tensing the thoracolumbar fascia from one PSIs to the other, hugging it together at the back. Because he has a pain response with this, I can see if it changes his pain, and that will give him buy-in for what I'm gonna give him, which is the most frustrating little exercises on the planet. Okay? Yeah, they should be. Okay, so there's the force filter. Now lift your left leg. And it hurts. Does it hurt with the compression? Just compression, just compression.
Better. But it's still, oh, that's better.
Yeah. So again, just like you say, Amy, you gotta play with the right place to have the compression, right? And for Chris, go again. Hang on, let me find the spot. So I'm compressing the inferior pole. Go again. Multifidus doesn't go that low. I don't think it'll work. This will be pelvic floor. I'm gonna compress the superior pole. Again.
It's better.
Yeah, so when I get right up to the top, which is where multifidus is, that makes it better for him. If he'd had a weak pelvic floor, weak ischiococcygeias, trauma to his floor, he would prefer compression being a bit lower. So it depends on what the deficit is, where they like the compression. So I am going to, for sure, for his pelvis, start stage 1, 2, and then into stage 3 training for pelvic control. There is nothing to release, all right? The compression that he has is probably secondary to the strategy he's using because he doesn't have good posterior force closure of his pelvis on that side. What's the time? 1/4 a mouse.
Yeah, 10:25.
Oh, look at that, 5 minutes, okay. Leg down straight. Actually, look up straight. Now, this isn't a full assessment of the hip, all right? I haven't done active mobility. I'm gonna go straight into passive mobility because I have 5 minutes, all right? So I wanna see what happens to this left femoral head. So on his left hip, it stays anterior and lying as well. This is not his meaningful task. His meaningful task is hiking and lifting up. Straighten your legs back down for me now. And it just stays anterior. Okay, so there is no position that I can place this hip where the femoral head is really centered. So I'm going to center this hip now. So now I'm just blocking the innominate at the back. The heel of my hand comes below the inguinal ligament so that it scoops right over the femoral head. I'm going to distract, posteriorly glide and distract the hip by pushing the hip posterolaterally along the line of the neck of the femur, counter pressure on the innominate, and I'm going to release and listen. Okay, this is the soap on a rope. This is the lacrosse ball with the elastic bands attached to it. Okay, and I'm going to listen. Okay, so the first vector, and you saw how much I let it go. Okay, The first vector is an external rotator. So the first thing that happens is the head of the femur spins into external rotation. Then it compresses medially and superiorly, but it doesn't go beyond the ramus. So I don't have psoas, I don't have iliacus, I don't have TFL. I have to explore something in the adductors. You're gonna love this test, Amy. Something in the adductors and an external rotator. All right? So I would then go palpate piriformis, obturator internus, and externus. Let's start with the externus, because that's where I think it is. So you come down along the inguinal ligament. You find an opening between pectineus and adductor longus. You slide your thumbs through that opening. Press back onto the foramen.
Some tenderness.
Some tenderness. Usually people are jumping off the table. Huh? You tend to ignore pain, no kidding. Alright, so tell me, this is also, I'm going onto his posterior for your pelvis. You always tell them what they're going to do. You put the pelvis here, you show them where you're going to go. He's a physical therapist. I'm going medial to the ischial tuberosity. I'm staying lateral. I'm not going anywhere near the anus or your genitals. You good with that?
Just making sure everything's to the right.
Yeah. Okay, there you go. Okay, so here's the ischial tuberosity. I'm going to slide up and then push lateral. Okay, how does that feel compared to the
The first, the anterior is more tender, yeah.
this one's definitely more tender. Compare that to, I find the ILA. I come lateral. What am I on to now? Piriformis. Compare that to that. They say sometimes are equally as tender.
I feel like you do press as much as you did before in the front.
No,
I was waiting for you.
I didn't, because I wanted to
was waiting for you to do that.
Yeah, because I have to be really careful with the obturator artery and the nerve, so I have to, when I go in.
Yeah, I couldn't go until control. That's more tender right there. Sure.
Okay, so my vector analysis is external rotators first, and so I'm gonna go and do a release technique on the obturator externus and piriformis. So when we get into treatment this afternoon, what we're gonna do over the next few days is we're gonna release Chris's hip, his piriformis, his obturator externus. We're gonna teach him how to find his multifidus, and our goal is that by Monday when he leaves, he can center his hip under his pelvis, and he may not have pelvic control. It's gonna take him 4 to 6 weeks. But when he show him how to tape his pelvis, so when he comes back in part 2, we want pelvic control and a centered left hip. Then we're gonna go target his thorax in part 2. Okay? Sound all right?
I'm on.
Ah, there you go. Okay, that is an ISM assessment and treatment session. And if I'd started on time, well, I still finished. I have a minute to chart.
Yeah.
Okay?
Oh yeah.
All right? Okay, time for a short break, and it's time for you now to start to learn how to, we're gonna start with the pelvis and the hip today. And because I want to leave the thorax so that for this afternoon for you to see what, and you won't be able to see a difference in Chris's multifidus with the ring corrections, because I can't correct them. I got to treat them first, right? I got to release the thorax.
It was very interesting because we were doing
Thank you,
yesterday,
Gabby. Yep.
and I thought I was correcting his rings,